Very good evening, everyone. I, Dr. Harshal Chaudhary from Merck, welcomes you for today's scientific symposium. Today is a very auspicious day. It's the birthday of Dr. Sir James Black, and he invented beta blockers. We celebrate this day, that is 14 June, as Beta Blocker Day, the month June as Beta Blocker Month. And for that, Associations of Physicians of India and Merck jointly brings you a scientific feast on beta blockers. Beta blockers, a revolutionary discovery. So I welcome you all for today's symposium. Next slide, please. We have Dr. Mangesh Tivaskar, sir, who is editor-in-chief of Journal of Associations of Physicians of India. He's a senior consultant physician and diabetologist. He's a formal general secretary, API, ICP, PRF, formal advisory committee, member of American College of Physicians Indian chapter, and in numerous publications, many awards and achievements sir has. Sir will be today's moderator for this session. And without much ado, I just hand over the session to our esteemed moderator, Dr. Mangesh Tivaskar, sir, for taking the session ahead and introduce our esteemed faculty. Over to you, sir.
Namaskar, good evening. Welcome to this very unique and very lively program, a new concept from entire team Merck, along with the Association of Physicians of India, and especially the Journal of Association of Physicians India. I take a proud privilege in welcoming you all for this very special symposium on beta blockers, and especially today, as Dr. Harshal has pointed out, that it is a birth anniversary of the inventor of the beta blocker, Professor Dr. James White Black. Now, we all know, friends, that beta blockers have a unique mechanism of action. They are the class of the medications which have been used for the treatment of various cardiovascular conditions like hypertension, angina, heart failure, arrhythmias, as well as there are a few other conditions where you can use beta blockers like glaucoma or migraine prophylaxis, or even in anxiety disorders, mitral valve prolapse. These are all the other indications where beta blockers have proved their effectivity and efficacy. Talking about the discovery, probably we have got one of the most eminent cardiologists of the country, Professor Dr. H.K. Chopra, who would be speaking about the entire journey of beta blockers, its invention, and how it has evolved in the field of cardiology as far as the management of hypertension is concerned. Then, next in the agenda, we'll hear from one of the teachers of cardiology, Professor Dr. Meenakshi Chenniyappan, and he would be teaching and talking to us about how to use beta blockers in your clinical practice. And then I have a phenomenal panel discussion with all the teachers, Professor H.K. Chopra, Dr. Chenniyappan, and then on the top of it, the icing on the cake would be Professor Dr. Chandrasekhar Ponde from PD Hinduja Hospital. Who doesn't know him? Bas naam hi kafi hai. And of course, I'll have Professor Dr. G.S. Wonder. And we all know these four gentle giants in the field of cardiology has made a huge difference as far as the cardiology is concerned in this country. Now, talking about beta blockers, we all are aware that the mechanism of beta blocker action is to block the beta adrenergic receptors. We all know that there are three different beta adrenergic receptors, beta 1, beta 2, and beta 3. I'll not dwell into it. Dr. Chenniyappan is going to speak about it. And they are all distributed ubiquitously in the cardiovascular system and the other various tissues. Now, we know that blocking these receptors would not only reduce down the workload of the heart, but also will lower the heart rate and will control the blood pressure because of the vasodilatory effect. Now, we know that they are wonderful drugs to treat even the conditions apart from the cardiovascular situations like migraine, like glaucoma, like essential tremors, like anxiety disorders. Then came the generations of the beta blockers. Initially, we had the first generation beta blockers in the form of propranolol and sotalol and timolol. And then we do have the cardioselective beta blockers like atenolol, metoprolol. And then we have got vasodilating supercardioselective beta blockers in the form of bisoprolol, carvedilol, and nebivolol. The research continues in the field of beta blocking. We all are aware that few of the global bestowing guidelines on hypertension, they have probably negated the use of beta blockers as a first use in the management of hypertension. but it was this European Society of Hypertension and the European Society of Cardiology guidelines, which were released in 2023, again got back these beta blockers in the mainstream of the drugs, where the efforts of legends like Dr. H.K. Chopra, Dr. Cheniappan, Dr. Shekhar Ponde, and of course Dr. G.S. Wonder, especially the contributions from India, have really made the difference. So friends, it is my proud privilege to first pay a tribute to Professor Dr. James Black, and I would request the tech team to play the video of tribute to Dr. James Black, who invented beta blockers as well as one of the other drugs which has changed the way we manage the acid peptic disease. Gone are those days where we used to do GJ vagotomies for the patients, those who used to have the severe acid peptic disease and reflux disorders. He invented cimetidine as well. So over to you, tech team. Harshal, can you ask our tech team to play the tribute video, please? Thank you.
Throughout history, breakthroughs in medicine have changed the course of human health. Today, we explore the story of one such breakthrough, that is, beta blockers. We know that heart is the most powerful organ of our body, which acts as the engine of our lives. This engine can face challenges sometimes. In 1960s, one day, a scientist named Sir James Black, while researching compounds to counteract adrenaline, observed that his research took an unexpected turn and made a remarkable discovery. He synthesized a molecule that blocked specific receptors in the heart, leading to the birth of the first beta blocker. This groundbreaking discovery became one of the most important contributions to clinical medicine and pharmacology of the 20th century. Since then, beta blockers have become a cornerstone in the management of heart disease. Years of research and dedication have brought forth numerous beta blockers like propranolol, sotalol, atenolol, metoprolol, bisoprolol, carvedilol, and nebivolol, each with its unique contribution. This month, on the occasion of centennial birth anniversary of Sir James Black, we at Merck, the forerunners and global leaders in beta blockers, take pride in paying tribute to Sir James Black and appeal to all healthcare professionals to celebrate the revolutionary discovery of beta blockers and spread smiles to millions of hearts.
Wow, that was wonderful. So as you must have seen, it is so exciting to have this molecule at our bay to manage our cardiovascular challenges very effectively. Mind well, Dr. James Black was stimulated to invent this basically because his father was admitted in the intensive care unit with acute myocardial infarction, and he had a very high rate and atrial fibrillation. So to talk about it, how it all happened, I have got one of the legends in cardiology, teacher of teachers from Delhi, Professor Dr. H.K. Chopra. Chopra sir, over to you for your comments, your remarks, your tribute to Professor Dr. James Black. Over to you, sir.
Dear friends, ladies and gentlemen, it's really a great pleasure and honor indeed for me to be here on the platform of Beta Blocker Day Symposium being jointly organized by the academic partnership of none other than Merck and JAPI. At the outset, I express my gratitude and thanks to Dr. Mangesh Tiwaskar, who is a very popular chief editor of JAPI and who is the moderator of this symposium. Our national speaker, Dr. M. Shinyapan and the national experts needs no introduction, Dr. G.S. Wander and C.K. Pandey, who has already been introduced by Dr. Mangeshkar in great details, and each and every one from Merck. What is the main theme today of this symposium? I was very impressed by the topic, the Beta Blocker Day Symposium. The theme is to celebrate 100th birthday of Sir James White Black on June 14th, that is today, and pay tribute to a lasting legacy of Sir James Black pioneering an iconic work of the century on beta blocker, saving many lives across the world. Ladies and gentlemen, we also have a very important component of this symposium today to discuss the power, promise, and potential of beta blockers in hypertension, heart failure, and tachyarrhythmias, and um, many other indications are there, which has already been expressed very well by Dr. Mangeshkar. A tribute to Sir James Black, the father, the icon, the legend, luminary, and pioneer of beta blocker in the world today. I, on behalf of each and every one of medical faculty in India and in the world, as well as on behalf of Merck, express my heartfelt tribute to Sir James Black for this unique discovering the most promising molecule to prevent and treat hypertension, heart failure, coronary artery disease, and tachyarrhythmias. Ladies and gentlemen, today is Sir James Black centenary birthday celebration, 100 years. 14 June 1924, he was born, and today is 14 June 2024. We all know the significance of blockers. You already heard from Dr. Mangesh. Commonly used to manage only one main thing is sympathetic overdrive, that is reducing the heart rate and the blood pressure. It is a sympathetic activation which is very, very important and comes before the RAS activation. Since their discovery, they have transformed the treatment of heart diseases and related conditions. Beta blockers, as you heard, is the cornerstones of cardiovascular therapy. No cardiovascular therapy is possible without beta blockers, whether it's hypertension or heart failure or CAD or tachyarrhythmias. Ladies and gentlemen, beta blocker discovery is the testament to the unexpected nature of scientific discovery of lasting legacy of Sir James Black pioneering work. It was year 1960, he conceived the idea that something should be done. And you already heard Dr. Tiwaskar mention very nicely, because Sir James Black's father had an acute MI. And initial research goal was development of new treatment for angina pectoris. That was the main objective. It was an excellent discovery, unexpected nature by a Scottish pharmacologist, Sir James Black. It was unpredicted outcome during research aimed at developing new treatment for heart conditions. And ladies and gentlemen, beta blocker discovery motivation was by sudden death of Sir James Black's father. As already mentioned, he had acute MI and atrial fibrillation. Sir James Black was thinking all the time as a medical student what we should do so that we could have reduced the heart rate and prevented this jeopardy. He was very keen to stop the effect of adrenaline on the heart and thus improve the chest pain of ischemic heart disease caused by lack of oxygen in the heart. Sir James Black deliberately built a drug which would be similar enough to adrenaline to block the chemical receptors, but different enough not to trigger these potential harmful reactions. In 1960, following hard work of 4 years, Sir James Black invented propranolol. You just heard from Dr. Tiwaskar, the first commercially successful beta blocker as a eureka. This eureka is the concept achieved, perceived, executed, and structured by one man, Sir James Black. Isoprenaline, known to be selectively stimulating the heart, he wanted to create a long-acting version of isoprenaline. He replaced, this is very important thing, he replaced hydroxy group with chlorine atoms, dichloroisoprenaline, DCI. The result of doing this was losing the bronchodilatory effect, but block the response to isoprenaline. Eliquis work on beta blocker receptors confirmed blocking Eliquis beta blocker receptors and testing this compound DCI as a potential antagonist. Ladies and gentlemen, the first beta blocker was alprenolol, but refinement of this particular molecule led to the backbone of beta blockers, that is propranolol. I think this was very extensively used once upon a time, and all the indications were very nicely expressed by Dr. Mangesh. Beta blocker discovery is the greatest breakthrough when it comes to pharmaceutical against heart illness since the discovery of digitalis 200 years ago. This was expressed by Nobel Committee for awarding Nobel Prize in Medicine in 1988. After 10 years, it was published by Redford MJ et al. In the New England Journal of Medicine in 1998. See the expressions. And we just seen Merck celebrate the centenary birthday of Sir James Black, a visionary whose contribution to medicine have profoundly impacted countless lives. His pioneering work in pharmacology, particularly the development of beta blockers, revolutionized the treatment of heart diseases. 100th birthday, ladies and gentlemen. And we can see here a very, very important evolution to revolution. How the things were evolved and revolved around the world, the beta blockers. There is not a single cardiologist today who does not use the beta blockers. Starting from propranolol in 1960 and 74, sotalol, atenolol, metoprolol, and then in 1986 was the origin of bisoprolol, 38-year-old molecule. I personally believe this as a molecule of century. And I'm sure we have many expert panels and our speakers who are going to throw light on this subject. And of course, we have carvedilol and nebivolol. And ladies and gentlemen, I will just say a few words about the uniqueness of bisoprolol because Mangesh Tewaskar was very kind to me to publish 3 important consensus on bisoprolol only in 1 year. I am very grateful to him. And they are very well covered by academia almost all over the world. 47 million of people have seen this consensus. And what are the uniqueness? The mortality benefit. The mortality benefit, CVD mortality, all-cause mortality, and sudden cardiac death reduction of almost to a tune of 44%, and reversal of cardiac remodeling, reversal with a robust survival rate, all the trials. And then we see the morbidity benefit in the form of MACE reduction, heart failure hospitalization, worsening in severity of heart failure in tachyarrhythmias. And of course, the functional benefits have also been documented in the form of improvement in the 6 minutes walking distance, KCCQ score, and reduction of NT-proBNP. All the trials. I won't speak in details because it will be overriding the speakers, whether CBS 1, CBS 2, CBS 3, MRFIT, Capricorn, Copernicus, or even the guidelines of ACC, AHA, and EAC recently published in 2023. Sir James Black in 1988 received, he was born very close to a place in Glasgow in 1924. Nobel Prize in Physiology and Medicine in 1988 at National Museum of Scotland. Sir James Black was one of the greatest Scottish scientists of the modern era. His work in medicine and pharmacology has improved the quality of life for an enormous number of individuals. Ladies and gentlemen, Millions of people around the world over last 100 years are benefited by discovery of Sir James Black. To conclude, ladies and gentlemen, our tribute and salute to Sir James Black on the occasion of centenary birthday of Sir James Black in his physical absence, but in his cosmic presence, consciousness presence, and quantum presence. Sir James Black is with us, inspiring us at every moment of life. His discovery on beta blockers has revolutionized the treatment of millions of patients, as I mentioned, on hypertension, heart failure, CAD, and tachyarrhythmias. Beta blocker discovery is here to teach us that to inform, perform, reform, and transform the whole world with beta blocker awareness and its usefulness in hypertension, heart failure, CAD, and tachyarrhythmias globally. And ladies and gentlemen, I must compliment JAPI as well as Merck to organize this important symposium by acting vocally as it is happening today, locally, focally, and impacting globally to sensitize the super selectivity in beta blocker bisoprolol today. Thank you very much for giving me this opportunity to be with you. With these few words, may I request and invite Dr. Chenyapan to talk on a very, very important issue, heterogeneous class of drugs, beta blocker selectivity matters. Dr. Chenyapan, sir.
Fantastic. It was just too good, sir. Thank you very much.
Can you make my sharing possible?
Yeah, sir. Chopra sir, you'll have to, yeah, unshare. Yeah, now it is possible, sir.
Yeah.
So as Dr. Chenyapan starts, proudly friends, let me have an honor of formally introducing Dr. Chenyapan, sir. Sir, being one of the king cardiologists, the teacher of teachers, one of the best man in the country to teach ECGs and to do echocardiogram. And my one of the favorite cardiologists, Professor Dr. M. Chenyapan. And Chopra sir and Shekhar sir, and of course, Wonder sir. You would be surprised that when I took over as an editor, the first editorial in JAPI was written by Dr. Chenyapan sir. So thank you, sir, for that wonderful opportunity to me to have your editorial. Over to you. Thank you very much.
Thank you, Dr. Mangesh, for the very kind words. I may not deserve that, but anyway, thank you for inviting me to this wonderful symposium. And also my regards to esteemed faculty, Dr. Chopra, Dr. Wander, Dr. Pandey, and also thank Merck for this wonderful opportunity. So the topic given to me is that beta blockers, heterogeneous class of drugs, the sensitive matters, but I slightly want to change the topic as beta blockers from no to yes. So this is going to be a little more interesting topic to learn rather than the previous topic. So we all know the problems of sympathetic overdrive. If you have increase in sympathetic tone, you have a metabolic problem, neurohormonal problem, hemodynamic problem, and prothrombotic problem, which may result in conditions which can actually predispose to significant increase in cardiovascular mortality. And which drugs are there to block this sympathetic tone? It is only beta blockers. So when you use the beta blockers, the problem is there are a variety of beta receptors, beta 1 in the heart, beta 2 in the peripheral vessels, beta 3 in the urinary bladder, and also in the lipid tissues. But primarily what happens when you stimulate a beta 1 receptor in the heart is that inside the myocyte, the calcium is increasing, and thereby there is increase in contractility and heart rate. When you stimulate beta 2 receptors in the peripheral vessel, there is decrease in calcium inside the vascular cell. So there's exactly the opposite which happens. So it's a beautiful mechanism of stimulating beta 1 receptor to increase the heart rate and contractility and increasing the stroke volume. And the beta 2 stimulation will vasodilate and make the arteries to receive the cardiac output or stroke volume. So that's a beautiful mechanism the nature is put in for beta 1 and beta 2. Of course, the beta 2 receptor stimulation also helps in significant metabolic advantages, beta 2 receptor stimulation. But when you block a beta blocker with the beta 1 and beta 2 receptors, we have very good advantage of blocking beta 1 receptor, but we also have a big disadvantage of blocking beta 2 receptor. Not only it will produce a vasoconstriction, it will also have a significant metabolic abnormalities. That's why we must first of all understand many disadvantages of beta blockers are due to beta 2 blocking effects, which are responsible for many side effects and many contraindications for the beta blockers. So if you look at the beta blockers side effects like bronchospasm, erectile dysfunction, temperature and cold extremities, the dreams, the low sugar and hypoglycemia unawareness, and also, so all these side effects are primarily due to beta 2 blocking effect. And bradycardia, atherosclerotic hypertension, heart block are the class effects, but the primary disadvantage of beta 2 blocking is all this is because of you block also the beta 2 receptors. So that's why the beta blocker classification has been into selective and non-selective. So non-selective, the drug is propranolol. We are no longer talking about intrinsic sympathetic activity beta blockers. So on beta 1 selective, we have atenolol, bisoprolol, esmolol, metoprolol, and nebivolol. We also classify them into first generation, second generation, and also third generation, in which nebivolol and carvedilol may be coming. Carvedilol is a carvedilol and labetalol is beta and alpha blocking beta blockers. And of course, we have one more beta blocker with a class 3 effect, which is esotalol. So why they are heterogeneous? So I am coming to the first part of the lecture. So you could look at the varieties of the beta blockers, pharmacokinetics and pharmacodynamics. First of all, we look at how strong the drugs are in blocking the beta 1 receptor and how selective they are in blocking the beta 1 receptor, whether have intrinsic sympathetic activity. The lipophilicity is very important because only lipophilic beta blockers will cross the blood-brain barrier and block the centrally driven sympathetic overdrive and also the half-life. And also they may have some special properties. When you look at the beta 1 selectivity, it is great for the bisoprolol and also the ability to block beta 1 receptor. The potency is also very great for bisoprolol. Similarly, for nebivolol, both are great. But one disadvantage of nebivolol is this, because although we think the vasodilatory beta blocker is a nebivolol because of nitric oxide donating property, people are suspecting it may have slight increase in sympathetic activity, intrinsic sympathetic activity. That's why the heart rate reduction is not very great with nebivolol. And of course, when you look at the lipophilicity, best lipophilic beta blockers are propranolol and metoprolol. That's why they are used in the treatment of arrhythmias and prevention of sudden death, because they are the best lipophilic beta blockers. And also, when you look at the ability to block or the beta 1 selectivity, it is the greatest for nebivolol. Then comes bisoprolol. Then comes all your beta blockers. And please remember, the beta blockade component of carvedilol is non-selective. Only the alpha blocking effect of carvedilol is selective. That's why the carvedilol cannot be used in all the other conditions like asthma and also the visas and so on. So that's why we have the advantage of beta 1 selectivity and also the potency to block the beta 1 receptors. This is what I told you about. Although we think now we have the good beta 1 selectivity is there for bisoprolol and also nebivolol. Which one we select? So this is a comparison of all the parameters of the nebivolol versus atenolol. So you can see that nebivolol is very good to reduce peripheral vascular resistance because it's a vasodilated beta blocker. But when you look at the heart rate reduction is not great for nebivolol. That's why the bisoprolol, although they have similar beta 1 potency ratio, beta 1 selectivity ratio, bisoprolol scores over nebivolol by this point, especially in coronary heart disease, where you expect the heart reduction is the paramount. So that's about the heterogeneity of beta blockers. So in which condition we say big yes to beta blockers? That is in coronary heart disease, acute coronary syndrome, and chronic coronary syndrome. Heart failure, 3 beta blockers. tachyarrhythmias, hypertrophic cardiomyopathy, mitral prolapse, dissection, gestational hypertension are very big yes for beta blockers. So they have to be used on the beta blockers. And of course, hypertension is curry. The latest guidelines have once again gone back to beta blockers as the initial drugs. But even in these yes indications, sometimes we say no because of these problems. Whether we can use hypertension as an initial drug, what is the drug to be used in young hypertensives? Diabetes, we are hesitating to use, metabolic side effects, weight gain, perioperative use, smokers, COPD, peripheral vascular disease, erectile dysfunction, and CKD. In all these conditions, we hesitate to use beta blocker. And although yes is there, we hesitate to use that yes because of the presence of these factors. Let us see that whether it can be overcome with the newer beta blockers or a second generation beta blockers. So as far the hypertension is concerned, when you have to use beta blocker as the initial drug, it is definitely young females. So young females who are pregnant or who are likely to become pregnant. Any patient who's got a sympathetic overdrive with a tachycardia, increased sweating, cold, whenever you see that hypertension patient, you know it is a sympathetic overdrive. With APDs, VPDs, or the patient has got some arrhythmia, tachyarrhythmia, with pregnancy and anxiety white coat hypertension. And of course, the newer guideline, European Society of Hypertension, has added the beta blocker as the initial drug itself when compared to all the previous guidelines who had forgotten the beta blocker as the initial drug. And as far as then you can understand whether if I choose that cardioselective bisoprolol, whether it could be going to be effective as the older beta blockers in reducing my systolic and diastolic pressures. And it has been shown that bisoprolol is more effective than the existing beta blockers. It's not only selective and also potency ratio wise it's higher, and its ability to reduce blood pressure is much more than existing beta blockers. Then we come to the diabetes. Why we hesitate to use? The masking of hypoglycemia, prolonged hypoglycemia, worsening of hyperglycemia. We think no protection to nephropathy. We think all beta blockers increase insulin resistance. The most important point is weight gain. So this is how we don't use. Whereas when you look at the hypoglycemia and beta blockers, definitely beta blockers may make hypoglycemic unawareness, but by blocking only adrenergic stimulation. But they cannot block the muscarinic effect of hypoglycemia. So a patient on a beta blocker will continue to have sweating, but not the palpitation. So you have to educate the patient that whenever you get a low sugar, you will have sweating and not the palpitation. So that's why we can identify a hypoglycemic episode on a patient who is on a beta blocker. And of course, the cardioselective beta blockers is once again not associated with hypoglycemic unawareness. Then we look at this paper. Scientifically, it has been proven that the bisoprolol may not have significant hypoglycemia. And what is about hyperglycemia by the beta blocker? If you use a cardioselective beta blocker like bisoprolol, and you can see that the HbA1c is not significant. The glucose is not significantly increasing, and the HbA1c is also not significantly increasing with the bisoprolol, which tells us the hypoglycemic problem is not there and the hyperglycemic problem is not there. What about the weight loss? When you use bisoprolol when compared to the other beta blockers, the weight loss, the weight gain is not there, and if at all you can have even a total weight loss may be there when you use this cardioselective beta blockers. So the weight gain factor is also addressed. Then, of course, this is a very important, very old slide I used for last almost 15 to 20 years to tell the importance of a beta blocker usage in diabetics. For example, if you use a beta blocker in a non-diabetic versus diabetic, if you use a beta blocker in indicated situation like coronary heart disease, heart failure, or an LV dysfunction or a tachyarrhythmia, the decrease in mortality is 15 to 10% in non-diabetic, whereas it is 30 to 11% in a diabetic. So beta blocker used in a diabetic produce much more effect, much more reduction in mortality when compared to a non-diabetic. That's why it is very, very important to understand if you withhold a beta blocker in diabetic in indicated situations like coronary heart disease, heart failure, and arrhythmias, the mortality is doubled. So that's why the diabetes is there. Then we come to the heart failure. Now we talk about what is known as the cardiorenal syndrome, where heart failure can lead on to renal failure and renal failure lead on to heart failure. So once again, we must understand today the CKD patients are dying because of the heart, not because of the kidney. When early stages, they die of sudden death, and the later stages, they die of progressive heart failure. Once again, to prevent sudden death and to prevent progression of heart failure in later portions of a CKD, beta blocker should be there. Then the question comes, what beta blocker to be used in a patient with a kidney disease? You have to use a beta blocker which does not have a renal excretion. They are propranolol and carvedilol, and of course, the bisoprolol and nebivolol have got a balanced clearance. So the advantage is that you can use it in liver disease and use it in kidney disease. Propranolol, carvedilol, metoprolol cannot be used in liver disease, whereas atenolol cannot be used in kidney disease, whereas bisoprolol can be used in both because of balanced clearance. And of course, what about the dialysis patients? So this study has shown whether it is a prospective study when compared to all the other beta blockers or a carvedilol and other beta blockers, the all-cause mortality and also the major adverse event on a dialytic patient is significantly lowered for a bisoprolol. So in advanced CKD patients, definitely this beta blocker will have greater advantages. What about perioperative use of beta blocker? In olden days, I think Dr. Mangesh will remember that people used to stop beta blockers before surgery because the anesthetists are afraid of beta blockers. So today there is an indication to use a beta blocker, especially when you have risk factors like this. If a patient has got a high-risk surgery, the patient should be started on a beta blocker preoperatively. If it is an intermediate surgery, if the patient has got one or more this clinical risk factor, he has to be started on a beta blocker preoperatively. And also, any patient on a beta blocker, the beta blocker should be continued throughout the surgery. And once again, what beta blocker to be used? We have best evidence was bisoprolol. It is not enough to start a beta blocker on the previous night or as the patient is going in for surgery. It has to be started 10 days earlier. And you have to get the heart rate of less than 70 per minute. The significant reduction in post-operative cardiac mortality is achieved only when your pre-operative heart rate is less than 70. And that is achieved by the bisoprolol, which has got the best evidence. And what is very important, many of the surgeons after the surgery say you need not have any drugs, but you have started a beta blocker preoperatively and stopped that beta blocker post-discharge, the mortality is significantly increased. You are starting a beta blocker not for surgery. You are starting a beta blocker for a cardiac condition the patient has got. So the patient has to live longer to enjoy the benefits of surgery. For that, beta blocker should be continued post-operatively. Then, of course, we always stop the beta blocker whenever there's a BC there. But today, once again, the people are dying of cardiovascular disease in COPD. So it is a very difficult time for cardiologists because everybody is dying of cardiac disease. Cancer patients, diabetic patients, female patients, COPD patients, CKD patients, HIV patients, everybody is dying of cardiac disease. So people will come and ask that specialist, you will say, you did not die of my problem, you died of a cardiac problem. Go and ask a cardiologist. So once again, you can see that the primary death due to COPD is once again cardiovascular disease, 8 to 10 times more than respiratory failure. Every 10% decrease in your respiratory function, there is a mortality increase by 28%. So that's why it's very, very important to, especially when you have an acute exacerbation of COPD, there is increased risk of myocardial death and the risk of developing cardiovascular disease is almost 8% in COPD patient. So that's why to stop that, we need a beta blocker in COPD patient. But here only you can see that when you use a beta blocker, the problem is the bronchoconstriction. Why? The beta-2 receptor is blocked. So if you are not able to block the beta-2 receptor by a significant selective beta blocker by B1 receptor blockade, very interestingly, if you use a beta blocker in COPD, the response to beta-2 agonist becomes more because more beta receptors are exposed to this agonist. So not only when you use a selective beta blocker, you are going to decrease your cardiovascular mortality, you will make your beta agonist therapy to work better. So that's why it is very, very important to understand the use of beta blocker in COPD. So this is a comparison between the atenolol and bisoprolol. And here we are looking at the heart rate and we are looking at the airway resistance. If you see that heart rate reduction, it is similar to atenolol, indicating to you the beta blocking effect is the same as atenolol. But when you look at the airway resistance here, the airway resistance is just like placebo and it is not increased like atenolol. So you have the good effect of beta blocking effect without increase in airway resistance. So that's why this once again an indication of no becomes yes. And of course, in patients, in smokers, we hesitate to use beta blockers because of unopposed alpha constriction. Once again, it has been shown in smokers especially, when compared to the other beta blockers, bisoprolol will have better reduction in blood pressure because it is not going to touch your vasoconstriction and it is going to act only on the heart, reducing the heart rate and contractility and also reducing your blood pressure. What about lipids? We hesitate to use because it will significantly reduce HDL cholesterol. So the beta blockers will require. But when you use this selective beta blockers, you can see there is no significant decrease in HDL cholesterol. Even you can have some increase in HDL cholesterol. So once again, a big yes for a beta blocker in dyslipidemia. Then peripheral vascular disease. Once again, peripheral vascular disease, patients die of cardiac disease. They die of coronary heart disease. We also hesitate to use. But when you look at very big meta-analysis, there is no evidence suggests that beta blockers adversely affect all the symptoms of peripheral vascular disease. And definitely, when it is indicated, endothelin patient has got a coronary heart disease or a heart failure, PVD patient, you should not hesitate to use a beta blocker. And that beta blocker is likely to be bisoprolol. And of course, especially in coronary heart disease, in other hypertensive situation, you use nebivolol. But we hesitate to use nebivolol in coronary heart disease. So that's once again, in a PVD, where there is an indication to use a beta blocker, we should not hesitate to use that. Then what about erectile dysfunction? It's a very, very important problem in young hypertensives. That's why we don't use beta blockers in young hypertensives. Recently married man coming for hypertension, we don't touch the beta blocker, although he has got a sympathetic overdrive. So you can see, although we think these drugs are safer, enalapril and amlodipine, when compared to this, the sexual functions are actually become better when you use bisoprolol, when compared to the drugs which we think they are going to be beneficial in erectile dysfunction. So young patients where you are worried about erectile dysfunction, once again, a big yes from no is because of bisoprolol and also for nebivolol. So that's why if you think that whatever the conditions I told you, no has become yes because of the better selectivity of the beta blocker, because of the better potency of the beta blocker to block the beta receptors. So the best indication bisoprolol will be chronic coronary artery disease, reduction, heart failure, the reduced ejection fraction, young females, young hypertensives, perioperative situation, diabetes mellitus, dyslipidemia. And whenever you think you hesitate to use a beta blocker as the conditions I have listed for no, you can definitely use this beta blocker for yes. And most important problem is because of its dual excretion, you can use hypertension in both these situations. And of course, you have a usual contraindication like bradycardia, degrees of heart blocks for the contraindication. So ladies and gentlemen, a no from yes. We have traveled from no to yes in the beta blockers. Why we travel from no and what made it possible? What made this travel possible is the cardioselectivity of the beta blocker and the potency of the beta blocker to block the beta 1 receptors. Thank you for your patience.
Wow. What can I say, sir? That was an epic journey that you took all of us, and so nostalgic, sir. I am to be very honest to you. I still remember, friends, whenever I had a problem, whenever I had a presentation to do, whenever I had a challenge in especially preparing a talk on hypertension, diabetes, metabolic challenges, acute coronary syndrome, I always looked at Dr. Cheniappan, sir, and he always been generous enough to help me off. And today also you must have witnessed how he has mastered the art of presentation and of course, art of teaching. Now, friends, here is my great privilege to invite my another mentor, one of the champions of cardiology from Dayanand Medical College, Ludhiana, now also Dean of Medical College, Dayanand Medical College, Professor Dr. Gurpreet S. Wonder. What can I say about this young man? His magical, I would say, compassionate hand of guidance has always helped me to whatever I am today that you know me as. And also, I have Dr. Chandrasekhar Ponde, along with Dr. Chopra and Dr. Cheniappan, to probably guide us on some of the questions that you might as well have, whenever we are talking about beta blockers. So Dr. Ponde, one of the champion cardiologists from Hinduja Hospital, Mumbai, you come to Mumbai, enter Hinduja Hospital, and just say Dr. Shekhar Ponde, and there'll be 20 people jumping on you, willing to take you to him and try to help you out. Just as I told you, Dr. Shekhar Ponde in Mumbai as a cardiologist, bas naam hi kafi hai. I don't know how many accolades of appreciation that this fellow has. If I start talking about him, probably the whole evening will go away. So, with your permission, all four teachers of mine, can we have a panel discussion answer? So here is my first question. So before I start, let me also request all the participants to shoot all your questions on beta blockers and shoot all your difficult questions, because these are all king teachers that who will teach us about where we are supposed to maybe probably improve. So my first question comes to Dr. G.S. Wonder sir and Dr. Chopra sir. Sir, beta blockers have been highlighted as one of the first line options in generally whatever the class, not only in the hypertension but also the other conditions. Now, if you talk about the cardio-selectivity of the beta blockers, as Dr. Cheniappan sir was saying about, India was never away from beta blockers, if you all agree. And I'm so happy to confess to all of you that Cardiology Society of India, Hypertension Society of India, Association of Physicians of India, all were believing the ability of beta blockers. And in fact, I still remember Dr. Wonder saying that, was Mangesh, ye kuch bhi ho jaye, beta blockers cannot be waived off from our treatment. Dr. Chopra once told me that beta blockers are the ultimate prescriptions that you cannot wind it off. Whether you have got a cardiovascular challenge or you do not have, in every high risk patient, you are supposed to use beta blockers whenever there is an opportunity. So what are your thoughts, first to Dr. Wonder sir and then Chopra sir, on current status of beta blocker usage in India, how sensitized we are as far as choosing the beta blocker smartly? And here I am asking you about the very highly selective beta 1 blockers that we have, like bisoprolol. So Wonder sir.
Thank you, Mangesh, for the very kind words, and it's always a pleasure to see you, meet you, and one is humbled with the humility God has graced upon you. That was indeed a lovely talk by Dr. Cheniappan, and it surely sets the ball rolling for a panel discussion amongst all of us. And with Dr. Chopra and Dr. Ponde being there in the panel, I think it's a great honor for me to participate in this panel discussion. Coming to your question, yes, beta blockers are the mainstay of treatment in various cardiovascular disorders. And in fact, when I was doing my DM way back in 1988, that's the time, 87, that's the time when these trials on use of beta blockers in heart failure came up. And for some young physicians, prior to that, one of the contraindications for using beta blockers was heart failure. But as everybody in this audience would know, beta blockers are today indicated in all stages of heart failure except stage 4, patients in whom you would stabilize them and then put them on beta blockers. So in that sense, but one should keep in mind that there are only 3 beta blockers which are indicated in heart failure, and that is, as Dr. Cheniappan said, carvedilol, metoprolol succinate, and bisoprolol. Other beta blockers cannot be used in patients with heart failure because the evidence is with these 3 agents. Nebivolol in the seniors trial failed to show benefit in patients of heart failure. As you said, Mangesh, yes, patients of coronary artery disease, patients of hypertension. A couple of years back, actually, there was a phase because the central reduction of blood pressure was less with beta blockers, as was seen in the CAFE trial in a head-to-head comparison between atenolol and losartan. And people at that time, there was some feeling that beta blockers are reducing the central blood pressure less. But over a period of time, it has been realized that it was not a class effect. It was a actually drug effect. Primarily, those trials were done with atenolol. And in fact, most of the metoprolol initial trials and even with other newer beta blockers, that fear is actually one realizes that it is confounded, and one does not hesitate to use beta blockers. Dr. Cheniappan beautifully said diabetics derive greater benefits from beta blockers. So in that sense, as you said and as very rightly pointed out by Dr. Cheniappan, beta blockers should not be deprived, patients should not be deprived of beta blockers wherever there is a genuine indication.
Thank you, sir. Chopra, sir, your thoughts?
I think at the outset, I must express my gratitude to Dr. Wonder, who has been instrumental in helping me, structuring me all the consensus, whatever I published in JAPI, with the help of and editorship of Mangesh Devaskar. Just heard a very beautiful talk by Cheniappan. Very nice. I must say, hypertension, young, middle age, or old age, bisoprolol, like beta blocker, is always indicated. Until unless there is bradycardia or heart block, very well mentioned. Number two, about the heart failure. There is no controversy so far as the HEPREF is concerned. There is no controversy about the de novo heart failure or even a heart failure with cardiomyopathy, hypertrophic type or dilated type. No controversy of tachyarrhythmias. But there has been some controversy in HEPREF. And just month of April, there was a meta-analysis published in PubMed. They mentioned very clearly that the all-cause mortality reduction is seen even in HEPF with bisoprolol with multiple comorbidities. But we need more data. So I think this is a very important thing we are learning.
Yes.
And I'm very happy to share that we are going to have the next book along with me, Dr. Wonder and Dr. Pandey. Both are involved in HEPF. So this is going to be a new vistas, a new indication. I personally believe may be a compelling indication on all-cause mortality reduction, but this is an indication.
Wow.
Third thing, I had a privilege of working with Parlov in the United States during my stay with Naveen Sinanda. Parlov came in our lab and he said, I will show you this patient has got autonomic insufficiency or sympathetic dysautonomia with a significant mitral collapse. So beta blocker, as Dr. Mangesh mentioned in the initial talk, is one of the very important indications in mitral collapse. The next very important, which I feel and very powerful, promising indication is stress cardiomyopathy. Tocosum, one of the very important indication which we see in most of our patients is very, very important. And already Dr. Mangesh mentioned about the anxiety state, neurosis. A lot of female patients. I feel women are more sensitive than men. I don't know Wanda agrees and Wanda agrees with me or not, but definitely they need more beta blocker than men because the dysautonomia is more in women. The power potential in CKD is very well highlighted by Dr. Cheniappan. I think he mentioned any degree of CKD, whether it's stage 4 or stage 3, pre-dialysis, during dialysis, post-dialysis, even post-transplant. Beta blocker is the mainstay. So you can understand the power. So I think in every patient with comorbidity, which is hypertension infected comorbidity, even stroke, as mentioned, dissection of aorta in one of your slides, I think this drug is of a great choice. This is what I wanted to express, that beta blocker has a very wide spectrum of indications in cardiovascular armamentary.
Outstanding. Thank you very much, sir, for those, in fact, most elaborate answers. Now I come to Dr. Ponde, sir. Shekhar, sir, are you around? This is a question for you, and this is a little tricky question that I have.
Yeah.
Looking at so many comorbidities like hypertension, diabetes, or even dyslipidemia, as Dr. Cheniappan sir was talking about. There are so many combinations along with beta blocker based therapies that we have. So what are your best choices? And this question is for both Dr. Wander sir and Dr. Ponde sir. So first, Dr. Ponde, uh, hypertension as a compelling indication, fairly very well established. Hypertension as a heart failure, fairly very well established. But here is a challenge. Which combination you would feel that would be the best choice when it comes to diabetes, when it comes to COPD, when it comes to metabolic syndrome, and when it comes to obesity?
Can Dr. Wanda take that first? Is
Yes.
it okay?
Okay.
Thanks.
Okay.
See, you have actually rightly pointed out we live in an era when we treat hypertension with combinations. The single drug therapy for hypertension is effective in only a very small fraction of patients only. So the basic ethos of treatment of hypertension is make combinations and make good combinations and pertinent combinations. Younger patients have increased sympathetic activity and they respond better to drugs, RAS blockers and beta blockers. Whereas elderly patients have more of a volume dependent hypertension and they somehow tend to respond better to the calcium channel blockers and diuretics. Coming to combinations, well, beta blockers, I would say the best combination is with the calcium channel blockers because of the benefit that one controls the heart rate and the other might increase, especially the dihydropyridine group. One caution, beta blockers and diuretics should never be combined because they both have metabolic effects, some dyslipidemia, some new onset diabetes, and especially with Indians having a very high percentage of metabolic syndrome, as you pointed out, one should avoid beta blockers and diuretics. Beta blockers with RAS blockers is not a bad combination. It's a fairly good combination.
Thank you. Thank you, sir. Ponde sir, your comments?
So your four comorbidities. One was you said
Diabetes,
the
hypertension,
diabetes.
COPD,
Yeah, diabetes, hypertension, and CKD. You said, right?
COPD, obesity, and
Acid
metabolism.
metabolic syndrome. So in type 2 diabetes, we know that the predominant. See, I think the way we learned the hypertension, there are four contributing things, which pathophysiological thing. One, volume, plasma volume. Second, sympathetic activity. Third, RAS activity. And fourth, and which we often tend to forget, is the baroreceptor hyperactivation. So these four are the pillars of driving forces of hypertension. If you take the typical metabolic syndrome patient, he has more of volume, very modest activation of very, very minimal activation of sympathetic system, predominant RAS, and baroreceptor activity is negligible. If you take renovascular hypertension, their volumes are contracted, they have high RAS, high baroreceptor activity, and modest activation of sympathetic system. And similarly, every phenotype changes like that. And therefore, in type 2 diabetes, the RAS is the predominant culprit. And I think their RAS blockers, either ACE inhibitors or ARBs, will be first choice. But uh, having said that, one has to individualize. For example, this India heart study that we did opened our eyes, saying that 81% of Indian hypertensives have resting heart rates above 80.
Mm.
So they are sympathetically driven hypertensive, no matter what the phenotype was. So there, as ESC now has said that at any stage of hypertension, you can add a beta blocker as an add-on drug, provided the resting heart rates are high. And we have got two or three big studies, done by Samir Dani from Gujarat, another done by Dr. Padmanabhan from South, that the Indian hypertensives are sympathetically driven. So here the beta blocker will come in use, in addition to the ACE or ARB. The metabolic syndrome with obese patients that Dr. Wander said, their problems are more metabolic and their diuretics and the beta blockers may not be the great choice. COPD patients, in the earlier days when we were students, we used to say COPD, no beta blocker, COPD, no beta blocker. But those time beta blockers were not so we were talking about only atenolol and other beta blockers. Now we have purely beta 1 selective, highest beta 1 selective bisoprolol, and in couple of studies, one in heart failure and one in hypertension, the bisoprolol treated group has actually shown marginal increase in FEV1 to FVC ratio over 3.5 years of follow. So they are, forget harmful, certainly not harmful beta blockers in hypertension. So in a patient with COPD who has got resting tachycardia and need for a beta blocker, I would not hesitate to use a small dose of selective beta blockers like bisoprolol. But what pleases my mind is we have really given tribute to Dr. Black today because beta blockers are a group of drugs has revolutionized cardiology from the time I was a student till I'm now here, from across the range of indications. Acute coronary syndrome, yes. Chronic coronary syndrome, yes. Heart failure with reduced ejection fraction, yes. Prevention of sudden cardiac death, yes. Hypertrophic cardiomyopathy, yes. Migraine, yes. Going ahead to hypertension, complicated hypertension, certainly yes. Even uncomplicated hypertension with high sympathetic activity at rest, yes, and so on and so forth. There is no end to the indications for beta blockers. But what makes me sad that despite the phenomenal benefits of beta blockers in reduction of mortality and morbidity in HEP-REF, the Kerala heart failure registry showed only 25% of our HEP-REF patients get beta blockers. And there was a one beautiful talk given by Dr. Tiny Nair in one of the conferences where Dr. Chopra was moderating and heading the conference, where he showed that much more than the expensive drug so far, the heart failure registry also showed, the Asia heart failure registry also showed, that even if you go one beta blocker, the 1 year mortality reduction was 36%. Then you can add ARNI on that and SGLT2 inhibitors on that. Then there could be some added mild to moderate benefit. But beta blockers are the fundamental pivotal drugs in reduction of mortality in heparin. So I think, yeah, we have to do a lot.
Absolutely, very well said, Shekhar. And honestly speaking, how medical science changes, as you say, as Wonder Sir was talking about, as Dr. Chopra and you, when you and me were residents and medicine students, if you are answered that you'll give beta blocker to a heart failure patient, you would fail. But now probably look at the whole perspective which has changed and how beautifully the whole thing developed. Now, Cheniappan sir, this is a very tricky question, and I would request Dr. Harshal Chowdhury that also please let me know the name of the doctor who is asking these questions, because I want to appreciate their question as well by calling their name. So the question which has come to you, Dr. Cheniappan sir, is how do you choose beta blocker in a diabetic 65-year-old female who is on with Lina, Cilnidipine, Telmisartan, Cilnidipine 20 milligrams, Telmisartan 80 milligrams, and she's also on with statin? Which beta blocker you will feel is the best?
Yeah, in this patient, first of all, you must know there's an indication for a beta blocker. For example, if the patient has got an additional coronary heart disease, whether the patient has got LV dysfunction, whether the patient has got an arrhythmia. So first of all, you must know whether in addition to all these drugs, you need a beta blocker. Once you decide on that, if you need a beta blocker, always I prefer, although we talked about bisoprolol, the best beta blocker in diabetes is carvedilol. Because the carvedilol is the only beta blocker which actually increases insulin sensitivity, and it is not actually increasing the insulin resistance. And the weight gain is significantly less when compared to all the other beta blockers for carvedilol. So if at all there is an indication to use a beta blocker in this situation, I will select carvedilol first. And if the patient has got wheezing and so on, then Viagra cannot be used, then of course I'll come to bisoprolol. So first of all, you must know, is there an indication to use a beta blocker? Because we are talking about beta blocker today, so we cannot just add a beta blocker to every diabetic. They must have an indication to use the beta blocker for that particular patient.
See, one of the benefits that has been always talked about of being there, and as you also in one of your lectures, I distinctly remember, talked about the importance of covering that plasma renin overactivity, which is generally seen in the diabetic patients, and its renoprotective benefit, because not only that it will reduce down the progression of nephropathy and albuminuria, but also by reducing down the renal hypoxia, which will reduce down the cardiovascular event through, inhibiting that cardiorenal axis.
Exactly.
And that sudden cardiac death, as usually you said, which generally happens in a very early phase of a CKD.
Exactly.
And patients, they die of a sudden cardiac death. Probably one of the, maybe probably the pivotal actions of beta blocker is to inhibit that plasma renin hyperactivity,
Exactly.
which has the benefit. So would you
Yes.
throw a light on it, sir?
Yeah. So first of all, we must know that whether that patient is prone for a patient has got an arrhythmia, whether the patient has got an LVH, whether he's got a VPDs, malignant VPDs, whether he's a candidate for a sudden death, or whether the patient has got a basic substrate to develop that sort of arrhythmia. That's what we told, that the diabetes plus a tachyarrhythmia, beta blocker should be used. So, but I will not be using that primarily for renal protection. So
Yes.
I will not be using that as a primarily for renal protection, as
Yes.
we know that the best drugs for renal protection is ROS blockers. So we will not be using as a first line of drug for renal protection. Definitely, although it has got some benefit for the early renal, but those patients who are actually prone for heart failure, prone for arrhythmia, you use beta blocker.
Yeah, so these are all pleiotropic benefits.
Exactly. So pleiotropic. So you have to select the patient to use a beta blocker, because we cannot just use a beta blocker in every diabetic. When patients are already well controlled and also have a target blood pressure achieved, their kidneys are nicely protected, and they have already controlled blood pressure like 110 or 120, you don't add a beta blocker to further reduce blood pressure, which may produce more problems. So you must have an indication to use a beta blocker, and then select a beta blocker according to the indication.
Yeah, thank you. Thank you, sir. And this question was by Dr. Sarkar, Dr. Narendranath Sarkar. Maybe he is from which place he is, I am not aware. But thank you, Dr. Sarkar, for that question. The second question is to Dr. Wonder, sir. And this is again an interesting question. And this is by Dr. Shami. And thank you, Shami, Dr. Shami, for asking this question. We all are aware that, sir, these are all time-tested drugs. We still need them, and especially in young hypertensives with additional comorbidities like COPD or coronary artery disease. Why cannot we have a clear consensus, strongly advocating, voluntarily coming out with our position paper, as we have done with you and Dr. Chopra sir and Dr. Ponde sir and Dr. Jenyapan sir, as we published? I think we should need some more, promising data coming up from India. So what is your take on that? This is from Dr. Shami.
Gone are the days when we used to say data is not available from our country. There is a lot of data today from India also. And India participates in most of the multicentric trials today. So in that sense, you have an Indian component of any multicentric trial that happens in the world in that sense. Dr. Ponde mentioned about the India Heart Study. India Heart Study was a study which had 20,000 subjects. And as he said, increased sympathetic activity and a couple of other things. The incidence of mast hypertension was to the tune of 20%. White coat hypertension was to the tune of 14%. So some very important revelations. We also know Indian hypertension is different. Morning surge of blood pressure is more. So there are a whole lot of differences that we know, which are amply actually highlighted in the Indian guidelines on hypertension, where we have actually given India-centric thoughts regarding how best you treat hypertensives.
Yes.
It's not that we don't have Indian data, it's not that we don't have Indian guidelines, but I'm sure with Mangesh and Dr. Chopra being there, we will have shortly
Your guidelines
on this, what Dr. Shami is looking at.
Yes, thank you very much, sir. And Shekhar, this question is for you specifically addressed to, and this is by Dr. Padmanabhan. So, Dr. Shekhar, they want to know now, as Dr. Wander sir has really said, especially the morning surge of hypertension, talking about non-dippers and all that. What would be the right time to administer bisoprolol? Morning time, afternoon time, evening time, bedtime, especially when it is used as a monotherapy.
Yeah. Now there are two aspects to this. We have all known about Professor Hizazi's two back-to-back papers. one in 2019 and another in 2021, saying that if the patient is on a single pill combination of any two classes of drugs, a nocturnal administration of that pill controls the 24-hour blood pressure better, and at the same time takes care of the non-dipping pattern of the blood pressure at night. Now, keeping that Indian data in perspective, as Dr. Sarkar has said, uh, in India Heart study and in the India ABP, sorry, not India Heart, India ABPM study, 23,000 humongous number of patients, we saw 42% of Indian patients have non-dipping pattern. Out of those who are non-dippers, all right, 8% are reverse dippers. Reverse dippers. So that means their blood pressure rises in the night.
Yeah, increase.
And which are these group of patients who have the typical non-dipping pattern? Type 2 diabetes, metabolic syndrome, obstructive sleep apnea, and CKD. These are the four background factors for typical non-dipping pattern. So if you have such a patient, you would probably give, and if you are giving a single pill combination, I would probably give at night.
Yes.
But again, Indian hypertensive patients have higher resting heart rate. And contrary to early morning surge in Western Caucasian population, we have usually higher blood pressures in the evening hours in the India IBPM study and in the India IBPM study. Now, why is that difference? Whether it's racial, whether it is our lifestyle, whether it is our type A personalities, I don't know what. So then in that event, it makes sense that if you're given two drugs, one drug should be in the morning, late morning could be, that will cover the majority of the part of the early afternoon, evening, and another could be in the late night.
Absolutely.
That will be right.
And thank you for that answer, Shekhar. But friends, let me tell you that in the latest released ESH guidelines 2023, one more big recommendation that has come is that you do not have to really time the antihypertensive drugs.
Absolutely.
Whenever that is comfortable for the patients and the clinicians to use it, even though it is used once in a day and as a monotherapy, you can absolutely give that drug any time of the day. So this is a new development which has come into the recommendation of this new ESH guidelines. Now,
importance is to control the blood pressure other than the timing
of that. Yes, absolutely. I absolutely agree. So Chopra sir, there is a very interesting question by Dr. Gobinath Raman. Thank you very much, sir, for that question. You talked about the use of beta blockers in HFrEF and you're looking at it. Also in some data which is coming up in HFpEF, which would be a very promising data. But the question is, and to a certain extent, Dr. Chennappan sir has really covered it beautifully, but they want to know from you, is this that, what should I choose? Biso, metoprolol, or carvedilol, or nebivolol? Your answer, sir.
No, in which group of patients is that question? Sorry.
HFrEF.
Oh,
I think it's a very good question. All patients of HFrEF, we have seen that they have increased sympathetic activity, increased RAS activity, and increased NPS activity. So all these patients need a combination of bisoprolol and RNA. And if you see the guidelines, ACC, AHA, or EAC, class 1A recommendation is for HFrEF. HFrEF is there is no choice, there is no question. The best drug of choice is beta blockers. And I don't think there is any controversy of metoprolol versus bisoprolol. We already heard Dr. Chennappan so beautifully that the selectivity matters. That's the question. That's what he said. So I think the selectivity matters. Then I think bisoprolol definitely supersedes as compared to metoprolol. There is no ambiguity in our thought process. And the data which we published in JAPI over 3 times, I think we mentioned more about bisoprolol. And it was not by consensus. It is a consensus of more than 90 people, which of course were reviewed by Mangesh Tivaskar from India. And abroad also, people are going more towards the bisoprolol rather than metoprolol. And HFrEF, there is no doubt. So far as the HFpEF is concerned, as I mentioned to you very recently, in the April only, and data from PubMed, then only all-cause mortality benefits are seen as compared to HFrEF, where we see all-cause mortality reduction, CVD mortality reduction, and SCD mortality reduction. Besides the reduction of MACE and the reduction of severity of the heart failure and worsening of the heart failure, they are all the benefits shown in the HFrEF. But in HFpEF, they have shown definite reduction of all-cause mortality benefit. And then, of course, some compelling indications. When a patient has got atrial fibrillation or tachyarrhythmias, we give anyone a HFpEF. But we need more data because there is some controversy by AHA, which we should keep in mind because of the of increased filling pressures, which occurs in the heart failure, and beta blockers are not indicated there. If it is isolated HFpEF with no other compelling indications. So I think we should be very clear when a patient come to us, which patient should be given beta blocker and which should not. I personally use echo in every patient. And I find if the filling pressures are significantly high in HFpEF, 80% of patients, when I do an echo, I know their filling pressures are high. So we have to be guarded, or we can give some diuretics, reduce the filling pressures, and then add beta blockers. Beta blockers definitely reduce the sudden cardiac death. This is a more powerful potential, whether it's a HFpEF or HFpEF.
Thank you. Thank you very much, sir. Cheniapal sir, there's a beautiful question by Dr. Jeshi Sekhar. And he wants to know, you have already talked about it partially, but which would be the best group of the drug to combine with the selective beta blockers when you are talking about young hypertensive Indian patient with the sympathetic overactivity? So what is the best add-on?
So the combination, as Professor Wander already said, the best combination with the beta blocker is always dihydropyridine calcium channel blocker.
Correct.
Because they beautifully synergize the effects, because the beta blocker is acting on the cardiac output side and the calcium channel will act on the peripheral resistance side. So it is a beautiful combination. So beta blocker plus a calcium channel blocker. So once you achieve the heart rate by a beta blocker, still your blood pressure is not under control. We cannot escalate the beta blocker because your heart rate is almost around 60 or something. But still your BP is not under control. The best drug to be added will be an amlodipine there, because that will not affect your heart rate, but at the same time will have a significant benefit in reducing the blood pressure. And the third choice, if the patient has got always, the third choice is always a diuretic. So anywhere the third choice is always a diuretic here. So if the patient is still not controlled with the B plus C, then the third will be a diuretic, preferably a thiazide-like diuretic like clothiazide or indapamide. So, and of course, this is the flow of this thing. So we like to always, the beta blocker, my first choice combination is always a calcium channel blockers. But I'm not a very great fan of combining angiotensin inhibitor with a beta blocker, although the companies are coming with a huge combinations, because I'm not a very, in a pure hypertension. If you think the combination of beta blocker plus calcium channel blockers work much, much better than a beta blocker plus an ARB combination. So that's why I prefer to use a calcium channel blocker first. And then the third step, I may be adding an ARB or a diuretic depending upon the indication. So first choice is always a calcium channel blocker.
So pure non-complicated, without any renal involvement, patient, which is just purely uncontrolled hypertension with sympathetic overactivity.
Yes.
Probably the non-DHP calcium channel blockers are the best.
Yes.
But the moment there is a presence of albuminuria, maybe probably then their ARB like telmisartan.
Exactly.
Smart.
If there's a definite compelling indication is there.
Correct.
Use a particular drug. That's all compelling indication.
Correct.
So the compelling indication we cannot come out. For example, so that's why we have to add that particular drug. But what we are taking is a simple pure and hypertension. So without anything that you have to control the numbers. So definitely the calcium channel blocker will be my first choice.
Wonder sir, you have very interesting questions. Two questions. One from again Dr. Raman and Dr. Om Kumar. Professor Dr. Om Kumar has asked this, and I'll combine these two questions. Post-MI situation, beta blockers, surely we know why. We know which and what, but how long? And also when to discontinue?
It's a good, excellent question, I would say, because when the BHART study came, we realized that beta blockers should be given to all post-MI patients, and we were using it for lifelong period, and that's what we were made to believe. But there are many studies now which have come in the last couple of years that beyond 2 years you don't derive much benefit with the use of beta blockers. So I think it will have to be individualized, because I personally feel some element of LV dysfunction, you should not deny beta blockers to these patients. But yes, I know where they are coming from when they ask this question, because we have now data which shows that beta blockers can safely be withdrawn in, because see, any post MI patient, you would use lifelong aspirin, you would use lifelong statins, and you would like to use a RAS blocker in them and a beta blocker. That's what we have always been practicing. But there is some data which shows today that you can withdraw beta blockers after 2 years.
That is absolutely fantastic. Sir, Chopra sir, your comments on this?
I think it's a very important statement given by Dr. Wanda, that if you ask my personal opinion based on the data, if you give beta blocker, should be given for a long term if you really want to prevent sudden cardiac death. But as Dr. Wanda pointed out very rightly, that we have to individualize some patients. So we cannot make a universal blanket. So we must see the patient if we have some associated bradycardia or some contraindications where we should use. But overall, beta blocker is a very powerful, promising, and has a lot of potential in reducing the morbidity as well as mortality.
Yeah, thank you very much, sir. Dr. Haresh Jumani is a very, very close friend of mine and practices in Mumbai. He has asked a very, very basic question, that in ADA guidelines, in their hypertensive algorithm, beta blockers are still there, especially in the presence of a coronary artery disease. Why? The reason why is this, that this is an absolute indication, as you must have heard Professor Dr. Cheniappan sir talking about it, that whenever you have got a coronary artery disease, no matter it is acute or chronic, evidence of an atherosclerotic cardiovascular disease, any situation where you have got maybe probably heart failure with with reduced ejection fraction, and I'm more than sure about that. The data is going to come as far as in favor as far as the preserved ejection fraction is concerned. But these are all the indications which will call for the use of beta blockers, as Cheniappan sir teaches us, as these are all the compelling indications for the use of beta blockers, and preferably, the use of cardioselective, highly selective beta 1 blockers with reduced intrinsic sympathetic activity would be the great drug of choice. And here probably the data on bisoprolol is significantly promising these days with the latest, all these CBS group of the studies that has been published. Haresh also wants to ask about the use of beta blockers in CKD, as Dr. Cheniappan has already covered in his talk, Haresh, that in the early stage of CKD, beta blockers will stop the sudden cardiac death. In the later stages of CKD, when the patients they die of heart failure, beta blockers will stop them from getting a heart failure. Now, this is a question to Dr. Cheniappan sir, and this is from Dr. Choyal, and this would be the last question. Time is absolutely necessary to follow. We know that you are all overwhelmed with these questions, but I'll have to ask you that if at all there are any more questions, please do write to the Merck representative from your area or team Merck. We'll send these questions to all the champion experts here, and we would definitely get answers to your questions. So this is my final question for the evening. Dr. Choyal wants to know that she's a female who is 68 years old on telmisartan and amlodipine combination, and also hydrochlorothiazide combination of 45 and 12.5. Along with that, she is also on with the statin, atorvastatin, and her blood pressure is uncontrolled. Maybe probably she wanted to write down 180 or 100 or whatever the figure is. Will you consider addition of beta blocker in her? Cheniappan sir, you need to unmute yourself, sir.
Yeah. So whenever you use the 3 drugs with a diuretic at the optimal dose combination, still the BP is not under control. The patient comes into what is known as apparent resistant hypertension. So in this apparent resistant hypertension, you have to first rule out pseudo-resistant causes, such as the white coat effect, pseudo-hypertension, patient's compliance, physician's inertia. So only first you rule out pseudo-resistant causes. When you rule out, of course, the sleep apnea, all these things will be contributing to the resistance. Once you rule out a pseudo-resistance, this patient will come under true uncontrolled resistant hypertension. Then you have 4 options. Then you look at the heart rate. If the heart rate is more than 80, use a beta blocker. If your potassium is less than more than 4, if the heart rate is more than 80, you cannot use a beta blocker. But in spite of using a beta blocker, still you have heart rate more than 80, add a clonidine. If your potassium is less than 4.5, add spironolactone. That is one of the wonderful drugs in resistant hypertension. Your heart rate is less than 80, but your potassium is less than 4.5, then the drug of choice is spironolactone. When you have the potassium is more than 4.5 and also the heart rate is less than 60, then use alpha block. So
Yes.
this is how you select the fourth drug,
Correct.
depending upon the heart rate and potassium.
Thank you very much, sir. So with this, probably we come to the end of this wonderful, wonderful program jointly organized by Team Merck as well as the Association of Physicians of India and especially the Journal of Association of Physicians of India. It was a learning experience to me, and I'm more than sure about it that all the participants, those who have joined today evenings, would have definitely learned a lot more than they knew in the field of not only hypertension management, but these pearls of wisdom on beta blockers were absolutely outstanding for all of us. So I thank you, all of you, from my heart. Thank you for spending your times. We all know you can see Dr. Wonder, sir. Still, he is in the dress of cath lab. I don't know how much and how long he works. Whenever I meet him, he's always there with his cap and dress on. I don't know. The love for cardiology is infectious, sir, and contagious, honestly speaking. Thank you very much for spending your evenings. Dr. Chopra, sir, you have been the Bhishma Pitamaha of cardiology in India. Thank you very much. And Cheniappan, sir, what can I say? You are the best one that I know. I would continuously say that, whenever I have a challenge, I will always look at all of these 3, 4 gentle giants, those who have shared their evenings. And of course, no program can be successful without an active participation of all the participants, those who have joined us in the evening. Jayesh or Harshal or Tech team, can you let us know how many people have joined PAN across India? And of course, thank you very much for spending your evenings. I know that this is a working evening, and Chinyapan sir and Dr. Wonder sir has taught me always respect the people, those who have given you time, because time is love, and your love makes us special. So thank you for all your love and affection. I must say that we all love you. We all exist because of you. Thank you for spending your evenings with us. Jesh or Harshal, for the Thanksgiving from your side. Thank you very much, all of you again.
Thank you, Mangesh. So nice.
Harshal, you can take it.
Yeah. Thank you so much, all the eminent faculties, for accepting the invitation and spending time with us. It's proud moment for us. We are doing this Beta Blocker Month, Beta Blocker Day celebration across India. Last 10 years, 11 years, we are doing this. But this meeting, this day, today, 2024, is very special, very unique, because two things: the centenary anniversary, birth anniversary, and the eminent cardiologists like you answering so many questions around beta blocker that exists even today at the same time. I can't thank you enough to Dr. Chopra sir for his wonderful talk and the tribute given to Dr. Sir James Black. I also thanks to Dr. Chenyappan sir for changing the topic, and that is the most important thing, from no to yes, because that's the crux of the today's meeting, and he brought it so rightly. I must thanks to Dr. Gurpreet Wonder sir for elaborating from his rich experience the various insights he brought around beta blockers, and also thanks to Dr. C.K. Ponde sir for even emphasizing that even today we see that underuse of beta blocker, and there is so much need to emphasizing even today's era that we have to use the cardioselective beta blocker. Who actually needs it should not be deprived of it. So that's the message he gave. And I can't thank you enough to Dr. Mangesh Tivaskar sir for managing the whole show, and answering all the questions, moderating the whole event, and giving us opportunity to collaborate for this great initiative. So thank you so much.
I was on the safe side, Harshal. These are all people, those who are facing the difficult questions. So thank you for that wonderful opportunity.
And I must thank to our audience who are, we got almost 1,000 plus registrations, out of which we have almost 700 logins today, live attendee. And also this recording of this will be available for all the audience even further. And this will be, available for across institute in India for, beta blocker. This is a beta blocker celebration month. It's not for only 14 June, but it is for this whole month. So thank you so much for everyone for joining this meeting as well. Thank you, sir.
Thank you very much.
Stay safe and good night.
And Mangesh sir, addition to this, almost 100 doctors have attended physically. It is webcasted across country.
Wow.
So that is how the people have attended and shown their interest on even on the beta blockers, which is a more than 60 years old molecule. So thanks to all eminent faculties on behalf of Merck and all the attendees who are attending from different parts of the country.
And of course, thank you very much, Dilip and everybody, Dilip and Sripad and all everybody from Merck. Thank you. Good night. Thank you very much.
Good night.
Thank you, sir.
Thank you.
Bye-bye.
Have a pleasant evening ahead.
Bye-bye.
Bye.